Drugs for treating dermatological conditions. Students should be able to describe basic principles of topical dermatological pharmacology, identify medications for treating common skin diseases in athletes, apply current recommendations about therapeutic medications used in the management of common skin diseases in athletes, distinguish between medications used to treat bacterial, viral, and fungal skin infections, summarize antipyretic agents used to treat atopy and allergic skin reactions, and recognize signs and symptoms of severe skin reaction or infection, and know when to promptly refer a patient to a higher level of care provider. Individuals involved in athletic activities that involve being with others in close quarters and promoting skin-to-skin and bodily secretion contact can be particularly vulnerable to contracting skin diseases. The athletic trainer should have an understanding of basic etiology, clinical features, and swift management of common skin diseases, which is essential in preventing the spread of common and serious skin infections. Inflammatory conditions of the skin are often characterized by itching, which can be intense, and lesions, which can be recurrent. Although most skin conditions are benign and self-limiting, some skin infections can lead to septic shock, which can be life-threatening. Epidermal barriers protect the body against various physical, chemical, and microbial assaults from the outside and keep water and solutes from the inside from leaking out. Cells are continuously turned over to renew the epidermis and its barriers. The skin is an efficient physiochemical, microbial, and immunological barrier that exerts several protective functions, many of which are in the epidermis. The skin barrier biology and immune mechanisms closely interact. The two major pathophysiological processes involve the following: injury or infection that disrupts the antimicrobial properties of the skin, and autoimmune responses to antigens and the anti-inflammatory properties of the skin. Common pharmacological vehicles include powders, baths or soaks, foams, solutions, emollients, gels, creams, and ointments. Table 16.1 includes common topical pharmacological vehicles and dosage forms. Pharmacology of skin dressings. Dressings protect open lesions, facilitate healing, increase drug absorption, and protect the patient's clothing. Some examples of common dressings include gauze dressings and non-adherent pads, non-occlusive dressings, either for wet to dry or wet to moist, occlusive film dressings, foams, hydrocolloid and hydrogel dressings, and dermal adhesives. Gauze dressings and non-adherent pads are the most common non-occlusive dressings. These allow maximal airflow to reach the wound, which is at times preferred in healing, and allows the lesion to dry. Non-occlusive dressings, dressings wetted with a solution, usually saline, are used to help cleanse and debride thickened or crusted lesions. Some examples may include gauze, natural or synthetic bandages, cotton, rayon, polyester, or wool dressings used to prevent wounds from becoming contaminated. Occlusive film dressings. These are transparent films such as polyethylene or flexible, transparent, semi-permeable dressings that seal off a wound or increase the absorption and effectiveness of topical therapy. Some examples include Nexicare Tagaderm, waterproof transparent dressing, BioOcclusive, and Polyskin. Foams use propellant or air spray foam pump to generate a liquid that forms a continuous film as a consequence of the solvent's evaporation on the skin. Hydrocolloid or hydrogel dressings draw out fluid from the skin to form a gel. It can be applied with a gauze cover. Dermal adhesives are adhesives that include sticky strips of tape used to pull together the edges of a minor skin wound, and skin glue for topical application to hold closed easily approximated skin edges of wounds from surgical incisions. Some examples include steri-strips, leukostrips, and Dermabond skin glue. Treating keloids. A keloid is a hypertrophic scar or raised overgrowth of a scar site that differs from mature scars in areas such as surgical incisions. Keloids are more common in African Americans and occur more frequently in patients between the ages of 10 and 30 years of age. Treatments include invasive and non-invasive options. Invasive treatment options, such as intralesional injections, have been successful in reducing keloids. Non-invasive topical silicone gel is safe, effective treatments that reduce itching and discomfort. An ultra-thin layer of silicone gel is self-drying and works over 24-hour daily spans. This product may be applied by an athletic trainer. The gel increases hydration of the stratum corneum, and it protects the scar tissue from bacterial infection, and it helps to restore the balance between scar tissue formation and breakdown. Athletic trainers commonly use dermatological cleansing agents, including soaps, detergents, and solvents. Soap is the most popular cleanser, but synthetic detergents are also used. Acutely irritated, weeping, or oozing lesions are mostly comfortably cleaned with water or isotonic saline. Normal saline and potable tap water should be used as cleansing agents with superficial to full-thickness abrasions, incisions, or lacerations. Topical organic solvents can be drying and irritating and may cause allergic contact dermatitis. Moisturizers or emollients restore water and oils to the skin and help maintain skin hydration. These topical agents typically contain glycerin, mineral oil, or petroleum, and are available as lotions, creams, ointments, and bath oils. Stronger moisturizers contain 2% to 47% urea, 5 to 12% lactic acid, and 10% glycolic acid. Moisturizers are most effective when applied to already moistened skin, such as after a bath or shower. Cold creams are moisturizing over-the-counter emulsions of fat, such as beeswax and water. Moisturizing agents are used to treat a variety of dry skin conditions and can serve as a vehicle for applying medications over areas of skin. Drying agents decrease excessive moisture in areas such as between the toes or between folds of skin that can cause irritation and maceration. Powders dry macerated skin and reduce friction by absorbing moisture. Cornstarch and talc are most frequently used. Although talc is more effective, it may cause granulomas if inhaled and is no longer used in baby powders. Cornstarch may promote fungal growth. Aluminum chloride solutions are another type of drying agent, often useful in hyperhidrosis. Superabsorbent powders are occasionally required to dry very moist areas. Medicated powders containing drugs are helpful for treating and preventing fungal infections. Skin and soft tissue infections, SSTIs, are among the most common bacterial infections, posing considerable diagnostic and therapeutic challenges. Humans are a natural host for many bacterial species that colonize on the skin as normal flora. Predisposing factors to infection include minor trauma, pre-existing skin disease, poor hygiene, and depressed immune system of the host. The primary pathogens in skin and soft tissue infections include Streptococcus and Staphylococcus species, including MRSA. The more common bacterial skin and soft tissue infections found in the athletic training setting are methicillin-resistant Staphylococcus aureus, or MRSA, impetigo and eczema, purulent skin and soft tissue infections such as folliculitis, furuncles and carbuncles, and cutaneous abscesses. Non-purulent skin and soft tissue infections such as impetigo and eczema, purulent skin and soft tissue infections such as folliculitis, furuncles and carbuncles, and cutaneous abscesses. The diagnosis of bacterial infections is primarily based on the history and characteristic appearance of the lesions. Specimens sent for culture and antimicrobial susceptibility should be obtained from any questionable lesion. If patients have signs of systemic toxicity and bacteriemia or systemic inflammatory response syndrome, then the skin condition should be considered severe. It may require drainage and oral antibiotics to cure. Topical antibiotic agents. Topical antimicrobial agents may effectively reduce the rates of infections with acute skin trauma. Topical antibiotics, such as clindamycin, are used as primary or adjunctive treatments for acne vulgaris in patients who do not warrant or tolerate oral antibiotics. Bactroban has excellent gram-positive coverage and can be used to treat impetigo when deep tissues are not affected. Over-the-counter topical antibiotics such as bacitracin and polymyxin B have been replaced by topical petroleum for post-operative care of skin biopsy sites to prevent infection of scrapes. Over-the-counter topical antibiotics such as bacitracin and polymyxin B have been replaced by topical petroleum for post-operative care of a skin biopsy site and to prevent infection in scrapes, minor burns, and excoriations. Topical antibiotic agents such as the combination of neomycin, bacitracin, or polymyxin B neosporin may effectively reduce rates of infection with acute skin trauma. However, excessive use may promote resistance, hypersensitivity, and overall impede wound healing. Methicillin-resistant Staphylococcus aureus, also known as MRSA. This is a staph infection caused by bacterial strain that has acquired a specific gene that makes it resistant to antibiotic treatments with common penicillin and other drugs in the extended spectrum penicillin family. MRSA infection initially presents as a standard bacterial infection and is commonly confused with spider bites. MRSA can be resistant to multiple antibiotics. Recommended antibiotics for bacterial skin and soft tissue infections depend largely on the local prevalence and resistance patterns of MRSA. It is important for athletic trainers to understand the proper recognition, disposition, and management of MRSA infections. The physician who should maintain close contact with the athletic trainer in such cases should abide by the evolving guidelines for the management of these infections. Given the potential for rapid development of resistance, some antimicrobial agents are discouraged for the treatment of MRSA. For treatment of MRSA, and outpatient options may include clindamycin, Bactrim, Septra, or Vibromycin. Due to the communicable nature of the bacterial infection, the athletic trainer must not allow patients with active lesions to participate in sport, even when the lesions are covered. The athletic trainer is often required to monitor affected athletes who must complete a course of directed antibiotic therapy for at least 72 hours. Non-purulent and purulent infections. Non-purulent skin infections may include things like impetigo and eczema. Impetigo is a common and contagious superficial bacterial infection characterized by thin-walled sacs of fluid that rupture into honey-colored crusts, often occurring on the face. Impetigo is caused by the streptococci or staphylococci or both. It usually occurs in warm, humid conditions and is easily spread among people who are in close contact with another. Eczema is an ulcerative form of impetigo. The painful fluid or pus fluid sores cause redness of the skin, usually on the arms and legs, and may become ulcers that penetrate deeper into the dermis. Eczema may be accompanied by swollen lymph nodes in the affected area. Impetigo and eczema may cause mild pain and discomfort, and pruritus is common. Scratching may spread infection, inoculating both adjacent and non-adjacent skin. The athletic trainer must be able to identify serious non-purulent skin infections and refer the patient to their primary healthcare provider or dermatologist. Although impetigo has no standard therapy, gram staining and culturing of the pus and exudates from the skin lesions of impetigo and eczema are recommended to help identify whether Staphylococcus aureus or Streptococcus bacterium is the cause. Penicillin may be a viable treatment, or erythromycin or clindamycin if the patient is hypersensitive. Topical prescriptions of antibiotics may be available with fewer side effects. Purulent skin infections may include folliculitis, furuncles, and carbuncles. Folliculitis is a purulent superficial infection of the hair follicles, characterized by redness and the presence of fluid or pus-filled sacs at the base of the hair follicles. Furuncles or boils are deeper infections of the hair follicle, characterized by inflamed nodules that drain fluid. These can join together to form larger nodules called carbuncles. Furuncles are different than folliculitis, in which the inflammation is more superficial and pus is limited to the epidermis. Infection involving several adjacent furuncles produces a carbuncle, a coalescent inflammatory mass with pus draining from multiple follicular orifices. Carbuncles develop most commonly on the back of the neck and are typically larger and deeper than furuncles. Purulent bacterial skin infections are usually caused by the S. aureus, in which pus extends through the dermis into the subcutaneous tissue, where a small abscess forms. Athletes with purulent skin infections should be referred to a higher level care provider for culture of the purulent lesion and prescription for the appropriate antibiotics. Simple furuncles may be treated with warm compresses to promote drainage, but more fluctuant furuncles and carbuncles require incision and drainage. In most cases, topical antiseptic treatment is adequate and may include the following over-the-counter topical antibiotics, such as Bactroban or Neosporin. Systemic antimicrobials are usually unnecessary for purulent skin infections. However, the athletic trainer must monitor the patient for fever or other evidence of systemic infection. The decision to prescribe antibiotics is adjacent to incision and drainage and should be made based on the presence or absence. The decision to prescribe antibiotics directed against S. aureus as an adjunct to incision and drainage should be made based on the presence or absence of systemic inflammatory response syndrome. Abscesses. Cutaneous abscesses are a collection of pus within the dermis and deeper skin tissues. They are usually painful, tender, and fluctuant red nodules, often surmounted by a pustule and circulated by a rim of swelling. Cutaneous abscesses can be polymicrobial, containing regional skin flora or organisms from adjacent mucous membranes. An athletic trainer must be able to identify serious skin infections, such as cutaneous abscesses, and refer the patient to their primary healthcare provider and dermatologist. Many abscesses require incision, covering of the site with a dry dressing. Oral antibiotics may be necessary and needed. The athletic trainer must monitor the incision and the wound for the potential of developing MRSA, and monitor the site for healing. Fungal skin infections. Dermophytes. These are fungal organisms that live in the soil or on animals or humans, including a group of fungi that infect and survive mostly on dead keratin cells in the stratum corneum of the epidermis. There are approximately 40 different species of fungi that can cause dermatophytosis or ringworm, which is a misnomer since the condition is not caused by a parasitic worm. The most common dermatophytosis in the athletic training setting are Tinea capitis, Tinea corpus, Tinea curis, and Tinea pedis. Tinea capitis is a common fungal infection of the scalp, manifested by gray scaly patches and accompanied by mild hair loss in many cases. Tinea corpus is a fungal infection on the body, commonly referred to as ringworm. The name is gleaned from its characteristic ring-like appearance. Tinea curis is a fungal infection in the groin area, commonly referred to as jock itch, and tinea pedis is the most common fungal infection that affects the feet, commonly referred to as athlete's foot. Antifungals are used to treat candidiasis. Treatments of dermatophytosis varies by site but always involves a topical or oral antifungal. Identification of the specific organism by culture is unnecessary. However, culture may be also useful when overlying inflammation and bacterial infection are severe or are accompanied by alopecia. Athletes who participate in non-contact sports or have localized cases of fungal infections may initially be treated with topical preparations for 2 to 4 weeks. More widespread inflammatory or otherwise difficult to treat cases may require the use of a systemic antifungal drug, which can have substantial side effects. Oral antifungals are used for most nail and scalp infections and resist skin infections and are useful for patients unwilling or unable to adhere to prolonged topical regimens. Doses and durations differ by site of infection. Although these topical medications may have effect in the off-season, athletes in the middle of a competitive season should be treated immediately with oral antifungals. Topical treatment is typically required throughout the entire course of an athlete's season for 2 to 4 weeks in the off-season. Corticosteroids may be prescribed in addition to antifungal creams to help relieve the itching and inflammation. However, combining topical corticosteroids and antifungal creams should be avoided when possible because topical corticosteroids promote fungus growth. Candida is a ubiquitous yeast that resides harmlessly on the skin and mucous membranes until dampness, heat, and impaired local and systemic defenses provide a fertile environment for it to grow. Infections can occur anywhere and are most common in skin folds, digital web spaces, nails, genitals, cuticles, and the oral mucosa, also called thrush. Candida auroris is an emerging fungus and a multi-drug resistant organism that presents a serious global health threat. According to the CDC, C. auroris is resistant to multiple antifungal drugs that are commonly used to treat Candida infections. Most cases of candidiasis are treated by the prescriber with Lotrimin. These infections are often resistant to treatment. For extended care or difficult conditions, the patient should be referred to the next level of care for treatment with prescription medications. Viral skin infections, including herpes simplex and Moscholosum contagiosum. Two primary viral infections prevalent in the athletic training populations are herpes simplex and Musculosum contagiosum. Herpes simplex virus infection is common among athletes, especially those engaged in full skin-to-skin contact, such as wrestling or rugby. Musculocutaneous infection is the most common herpes simplex virus infection. This can occur on the skin, face, genitals, and may include pain clusters of small fluid-like sacs. The typical treatment for herpes includes Aclavar or Valaclavar, or an antibiotic if associated with infection. Herpes gladiatorium is common in wrestlers, and the treatment includes antiviral medications. Molluscum contagiosum is a highly infectious and contagious viral condition that commonly causes localized chronic infection. The transmission is by direct contact, and spread occurs via fomites, such as towels and bath sponges and bath water. Athletes acquire the infection via close skin-to-skin contact with an infected person in sports such as wrestling or rugby. This is usually a benign, mild skin disease that is characterized by lesions appearing anywhere on the body. The lesions are known as musculosa. These are small and raised like with a dimple or pit in the center. They're usually white or pink or flesh-colored and may have a pearly appearance. They may become itchy, sore, red, and swollen. With treatment, Musculosum contagiosum typically resolves without scarring after 6 to 12 months, but recovery may take as long as 4 years. Antivirals may help, and higher level care is required to continuously monitor the patient. Inflammatory skin conditions. Common inflammatory skin conditions such as urticaria, contact and atopic dermatitis, and psoriasis present with skin lesions and signs and symptoms in multiple body regions and are related to stimulation of the immune response. Most inflammatory skin diseases, such as mild urticaria or irritant contact dermatitis, can be managed clinically and are generally self-limiting. However, other skin conditions, such as atopic dermatitis, eczema, and psoriasis, are inflammatory dermatosis that often have an atypical presentation or do not respond well to over-the-counter treatments. These require referral to a dermatologist for treatment. Therapies may include corticosteroids, either topical or systemic, but may have potential complications. Treatment for pruritus, topical corticosteroids, including lotions or creams. And treatment for urticaria may include antihistamines, either Claritin or Benadryl. Dermatitis, eczema, and psoriasis. Dermatitis, we treat the symptoms. Over-the-counter topical corticosteroids or SOAKs are common. The prescription, most commonly we find non-sedating antihistamines, like Claritin. Atopic dermatitis, also known as atopic eczema, is a chronic pruritic inflammatory skin disease that is characterized by intense itching and recurrent eczematous lesions. Common triggers include airborne allergens, sweat, harsh soaps, rough fabrics, and fragrances. Atopic dermatitis often improves by adulthood. The goal is symptomatic treatment and avoiding oral corticosteroids. For atopic dermatitis and eczema, these are considered chronic inflammatory diseases. The treatment goal is to restore the epidermal barrier function. So symptomatic treatment with emollients is preferred and avoiding oral corticosteroids. Psoriasis manifests most commonly as well-circumscribed erythematous papules and plaques covered with silvery scales. Patches are typically found on the elbows, knees, scalp, lower back, face, palms, and the soles of the feet, but can affect other places as well. Symptoms are usually minimal, but mild to severe itching may occur. Over-the-counter and prescription options are available for the treatment of psoriasis. In summary, there are a variety of symptoms associated with dermatological disease, injury, or autoimmune responses. The skin has a protective function for the body. Athletic trainers must be aware of dermatological conditions that commonly affect our competitive athletes, and recommendations must be made to mitigate the spread of infection and disease via the management of skin diseases.